terms of treatment. So it goes through CBT or medication, which to choose first. Is the patient depressed? Do they have agitation or insomnia? What do you do second? How do you taper? How long do you treat? So I have said all those things. So given that we still have half the handout, I'm going to move on to panic disorders. Did he show you a person having a panic disorder?
Yeah.
Yes.
Mm-hmm.
It's frightening. My sister suffers from panic disorders, and the first time I saw her go through one, it's very frightening. She starts breathing very unusually. She has very severe ones, and then she usually loses consciousness within a short period of time. And then she gets very disoriented. But when I first saw her do it, what really bothered me was that she just says, "My heart hurts," and I'm like, "We're going to the emergency room," because it does look like a heart attack. And so but I have read after that is that there is something to that. Their heart really does hurt, but it's not angina. But it's a very frightening. It's frightening for them, embarrassing, and so it's a real thing. When people talk about it, it needs to be addressed. So the goal is to get them in remission and free of attacks and no functional impairment. So that all makes sense. Options are under general approach to treatment. So there's medications, there's psychotherapy, and there's combinations. So same thing we saw for general anxiety disorders. For patients who don't have agoraphobia, then meds may be enough. Usually agoraphobia will require medications and psychotherapy as well. Avoidance type of behaviors are slow to respond to therapy. So I put that in there just because it's one of the features associated with panic disorders. Non-pharmacologic, so avoiding knowing the precipitant. So having them keep a log, what precipitates it, what goes along with it, avoiding those triggers. Smoking can increase the risk, and exercise makes it better or helps them to cope better. CBT is very effective in this disorder. Up to 80 to 90% of patients will have improvement. So getting them into that therapy is very helpful. In terms of drugs, so what will we use? Again, SSRIs are the first line therapy for treatment. It's fairly, to get them panic-free, 60 to 80% of patients respond, so they're very effective. Again, it's the delay. It's usually up to 4 weeks before you see before you should even start to judge whether the drug is going to work, and sometimes up to 8 to 12 weeks. So preparing the patients, dealing with how will you treat a panic attack that happens during that time, and making sure they understand what the effects are going to be. Again, using low dose SSRIs is important. Realizing that if you do they experience activation, using a low dose benzodiazepine with that until the SSRI or the SNR can take effect. The same kinds of things we talked about before. If alcohol dependency is a problem, or drug abuse, then trying to avoid the benzodiazepines if possible. The ones that are preferred for short term are alprazolam because it's very quick, it's very effective, and also clonazepam. Those two are the preferred for panic attacks short term. I think I've said most of this at the bottom with the Xanax. Again, very powerful, very potent, very quick in onset, high withdrawal potential. It's very sedating. That's the biggest problem, is that it's hard for people to take throughout the day. They do make an extended release product that may work better for some, Otherwise, it has to be dosed 2 to 3 times a day. People will tend to use it more at night because it helps them with sleep or get to sleep. But during the day, it can really interfere with their ability to do their work. Acute phase, I think we picked most of those. So reducing their number of attacks, reduce their anxiety, their phobias, resuming normal activities, work, play, whatever they are engaged in. That's usually a 1 to 3. You can use the benzos during that time with your antidepressants. Under maintenance, usually we treat them at least 12 months before we start to taper them off. Here, if benzodiazepines have had to be used long-term, switching them to a longer-acting drug like the diazepam, and then that keeps the number or the withdrawal symptoms from occurring and also can help with the taper so that they're not so symptomatic during a tapering and going slow. So here, patients under evaluation, patients should be seen frequently and evaluated, especially in the acute phase, or when you've got a new drug, or you're tapering, or you're titrating. Having them chart their attacks. There is a product or a tool called the Panic Disorder Severity Scale, and I put it on D2L. I had trouble, let's see. I'm not going to take the time, but this was, Dr. Britton and I had, when I switched from you to another user, it just spun. So I turned the system off, so over lunch you probably are going to want to see if you can boot it back up. I don't have to have it. I was going to show them the panic disorder and the Sheehan disability scale that can be used. So you've got both of those posted to D2L. That's really, I have, the big difference with panic disorders is using the benzodiazepines, tapering them, watching out for withdrawal. Often these patients will will use a benzodiazepine with their antidepressant. So employing those same kind of concepts are the same. Questions about panic disorder? Comments? Yeah.
Question, is there an immediate release Klonopin or just immediate release Xanax?
Just, Xanax by itself is just short acting,
Okay.
rapid acting,
Okay.
onset. Clonazepam, no, there's no quicker acting.
Okay.
It's the light like the zero.
Oh, I saw that flash.
See, that's what caught my, I thought it was the computer, but it's, so we got a bowl that's going on. Okay, obsessive compulsive disorders. I should have brought a picture of Dr. Britton's desktop. He's very neat. I wouldn't say he's obsessive, but he's extremely neat. Used to, whenever I'd go into his office and I was going to move anything, I would take a picture and I would do whatever I had to do, and then I would put it back exactly where I could tell if I'd been in his office or in his little area.
Antisocial personality.
Before we had smartphones, I used to just draw it out.
We had desks facing each other at the University of Texas. Now, this is the best story.
When we first got married, yeah.
When we first got married, we had
the
two
only way
desks
we were
back to
able to
back. They
tolerate it.
didn't have enough space, so we shared an office because nobody else would. And hers was over here, and mine was here, and I took my ruler and I got all the junk back, and I said, and don't cross the line. Like, this is going to be mine. You can do whatever you want to. I can live with it. That's the true story.
That's true.
Never had a problem.
He does that at the house too. He has his room.
He's back.
I know we moved each other to the middle. I'm not as messy as I would have been. And he's more tolerant. I wouldn't say he's not any more neat, but he's more tolerant. He's had to make the bigger adjustment than me.
Okay, this is called adaptive personality.
What?
We're
What
talking
is?
about adaptive, that means we're not disordered yet, we're still adapting to things.
Okay. Okay, goals of therapy. I find this very interesting. So, of course, decreasing symptom frequency and severity, but the target is to have less than 1 hour a day spent obsessing and performing compulsive behaviors. Usually, we don't put time limits or time frames on our response. I found that a little bit interesting. First line therapy is CBT is really what you want people in. You want them to learn how to adapt to their disorder and keep it from disrupting their life and impairing their ability to be functional. SSRIs, again, are the go-to if you're going to use a drug. Here again, sometimes in the beginning, it's good to combine them so the patient can cooperate more with the behavioral therapy than maybe the drug does an effect. It lowers their obsession or obsessive activity so that they can then hear what they're being discussed in therapy. Most of the SSRIs are listed there. One of the other ones that has been shown to be very effective is clomipramine. Clomipramine is an old drug. It is one of the tricyclic antidepressants, so it's in the same category as amitriptyline. So that drug's been around probably 50 years or more. But it's very effective. The one thing that keeps it from being used is the side effects. So when you think tricyclics, think anticholinergic effect. So they tend to have the sedation. The sedation can be good, but it tends to bring a lot of hangover effect. So just like diphenhydramine, if you've taken it at night, you wake up kind of in a mental fog, and it takes a while for that to clear. The tricyclic antidepressants do the same. So clomipramine falls in that. But it has good data behind it. It's as effective as the SSRIs. It just has a different side effect profile. You'll see, if you go back and look at the notes, the tricyclics fall under the SNRIs. We didn't call them that, we called them tricyclics. But they have that they inhibit both norepinephrine and serotonin reuptake. So it's probably where their effectiveness comes in this situation, but you've got that anticholinergic luggage or baggage that you bring with it. Let's see, I've talked about some of these. I've covered everything in this next section, C, down to, if you look at, again, response, 4 to 6 weeks, treat them for at least 8 to 12 before you call it effective or ineffective. So all of those are the same, so that's good. You memorize it for one, you've got it for all of them. Next page, 13. In terms of alternate therapy, so it's those same augmenters we talked about with general anxiety disorder. So you can use Buspar, you can use the atypical antipsychotics. You want to be careful there. That would be in your more severe and extreme situation. Or venlafaxine has some data behind it as an SRNI instead of using an SSRI, or if you can't use clomipramine. Relapse is common, so using these meds for up to 2 years before a taper is employed is not uncommon, and a slow taper. So this is not using a benzodiazepine, this is using your antidepressants, but removing them all the time, monitoring therapy or monitoring reoccurrence of symptoms. Really isn't a whole lot more. Anything that I said that was a conflict of what you heard when you talked about the ClinMed portion of this. So the concepts are pretty much the same for these three that we have talked about, for panic disorders, general anxiety disorders, and obsessive compulsive disorders. Okay, let's move to insomnia. So here it's a little bit different. We're going to use different drugs. So the goal is you want to improve their sleep and decrease the dysfunction that results from that. So I bet you all, has anybody not ever had insomnia? Okay, good. Everybody can draw from their experiences. So tell me, what kinds of things are common with insomnia?
Shut your brain off.
Huh?
Shut your brain off.
Okay, shutting your brain off. So that impacts what? Your ability to do what? Go to sleep. Okay. So that's called like sleep sleep latency or sleep onset. What else?
Waking up early, you can't go back to sleep.
Waking up early, waking up in the middle of the night, can't go back to sleep. That's one of my favorites. So diminished sleep time. What's another? You ever slept long enough and you get up and go, I'm still tired? Okay, so not having long enough sleep. Okay, so the drugs that we use, and there's quite a variety here, will address those. So in the table that I've got for you, some of them it will show you these are for sleep onset. So you want to find out from the person, what type of insomnia do you have? If you have trouble getting to sleep, then we're going to use a different drug than we will that if you can't sleep long enough. And we'll use a different dosage form if you wake up in the middle of the night and can't go back to sleep. Okay. So did you all talk about sleep hygiene? Okay, so this will be so common, especially as you get older people. It's kind of like bowel habits. People kind of have an idea about what is normal and what's regular. And they'll do the same with sleep. So they'll tell you, I just don't sleep as long as I used to. So asking them about their sleep hygiene is really important. So what have you learned about things that people do that are good hygiene, bad hygiene?
Staying on phones and TVs in the bedrooms.
Okay, having been distractors. How many of you sleep with your smartphone? I do. It's right beside my pillow. I don't know why. It's because I use it as my alarm clock. Does anybody check their emails in the middle of the night, text? Okay, that's good. What, if it wakes you up? Okay. What other about sleep hygiene? So removing distractions, things that keep you stimulated. What else?
People only use, or Dr. Britton told us you should only use your bedroom for sleep, sex, and I can't remember the other S he said.
Sickness.
There you go.
Sickness, okay. Okay, so same kind of thing.
That guy gave
That guy
us,
did.
he said sleep, sex, and sick.
Okay, okay. Some of this goes with cueing. So let's talk about schedules. Those of you who have kids, schedule's good for a kid, not so good for a kid.
It's very good.
It's very good. If your child knows when they have to go to bed, when they're going to take a nap, when you're going to feed them, and when you're going to be there, is life usually better? It's better, okay? We are the same way. We just don't tend to enforce it on ourselves. The more you are in a schedule, the better you feel. So it's the same with sleep. If you are all over the place, and you'll find it with older folks and with people who do not work. This was my experience at Family Medicine. They have no schedule, no schedule. They may go to bed at 10 one night, they may go to bed at 4 in the morning the next. The body just doesn't adapt well. And so it never knows when you are going to go to sleep. So having a schedule, a routine. The body does well off of cues, like when you walk into the room, you know the body goes, okay, this is where we usually go to sleep, and you're doing it about the same time. All of those really do make a difference. And so reviewing those are very important. And getting people to move to that sometimes is easy, sometimes it's not. So when we talked about smoking cessation, remember one of the things I talked to you about was the brain associates behaviors with other behaviors. So I told you go home by a different route because you'll have to think about it differently. But if you smoke every day after you drink your cup of coffee, then one of the things we teach people in smoking cessation is sit at a different place at the table, use a different cup, and when you get through, instead of smoking the cigarette, get up, take your cup to the sink and wash it. Then the brain starts to think, okay, we're doing something different. And those cues are really important. So what he was telling you is the cueing. The body starts to realize that this room is for these things and this is what happens in this room. Instead of going to sleep at the couch or in a chair or in another bedroom and then moving to, the body gets all out of whack and you don't feel as good. Okay, what else did you learn? About sleep hygiene. What about alcohol, caffeine, those kind of things? What else do you talk about? Does alcohol help you get to sleep?
Yes.
Yeah. Does it help you stay asleep? No, it doesn't. Ruins your sleep cycles. Okay. What else did you learn about taking a history about sleep?
Whether or not they eat in bed.
Oh, yeah. So tell me more.
Just kind of like with the cueing that you said, instead of getting sleepy, they get hungry.
Yes. So they bring the food to the bed.
Yeah.
I had a couple that I saw one time. They were both about 350 to 400 pounds. So what they would do is they'd get their kids to sleep, and then they would get in bed, and they would do like bowls of food. And I'd say, okay, show me the bowl. Well, you know, a bowl. So they would get a mixing bowl of all kinds of sweet snacks, and they would sit in bed and watch stuff all night long until their child woke up. They packed them off to school, and then they would go to bed. Some of the most bizarre lives I've ever heard were just what patients would tell me. Okay, so they ate in bed the whole time. That was their table. That's where they did all their meals.
I had a woman who would she had a computer in her bedroom. That was a big mistake, because she would go sit on the computer and she would start her computer surfing at about 11 p.m. and surf until 3 or 4 a.m. And the whole time she was surfing, she was eating nuts, peanut jars, cashew jars, the whole thing. And I would ask her, how many would you eat? And she would tell me, and I figured she was getting about 4,000 or 5,000 calories in nuts when she was surfing the computer before she went to bed. And then she would awake at about noon and start the whole thing all over again. And she said, well, I just really don't eat that much. And I thought, you have to. You're 380, not eat.
Yeah.
So finally, it was a behavior in the bedroom before sleeping. It was totally bizarre.
So these are kind of all extremes, but doing a good sleep history is very important. And did he give you the guidelines? There's insomnia guidelines.
He didn't do it.
I'll post those. They came out last year, and they're really good about how to take history and what you should get. But do those, and then just talk about the simple things about sleep hygiene. It goes a long way if people will practice them before you go to a drug. Because these drugs, while they're effective, they are not long-term solutions. There's too many side effects with them. And they're really not intended for long-term use. So here are the different types of drugs that we have. We have benzodiazepines, so that we can use the short-acting or we can use the long-acting, depending on the type of insomnia. We have the non-benzodiazepines, and they're all over the commercials. Sonata, Ambien. Ambien is like, these three are like in the top 100 drug sales in the United States. Lunesta. You know, that's the little lunar moth that kind of floats all over the place. Belsomra is one of the more newer ones. Rosarim. I don't know much about it. I haven't seen it used that much, but we'll talk about it. The antidepressants, usually most of them have enough sedative qualities that you can use them that way. Doxepin is a very old drug, and it is one that is approved for this trazodone. I told you about one of the atypical antidepressants, very sedating. In fact, most people use it for sleep instead of as an antidepressant. People use antihistamines, diphenhydramine over the counter, you can get it. The other would be melatonin, which you can also get over the counter, and people frequently who fly across lots of time zones can use it to kind of reset their clock when they go to other countries. So those are all the drugs that we have. So there's quite a few, because a lot of drugs are sedating, so people take advantage of that side effect. So the choice of agent is going to depend on what is the person complaining about. Can't get to sleep, can't stay asleep, can't sleep long enough. Okay, so if you look at, let's go to the next page. So sleep onset insomnia. So we can use a rapid acting benzodiazepine. So the short actors. So like Halcyon. What are Halcyon? You know the term Halcyon, what that is? What is it, Dr. Britton?
Halcyon, I mean, the drug or
The name.
the name Halcyon, I think it's the Greek god for sleep.
It is. So Halcyon is a very short-acting trazolam, so it's very quick in onset. You can use it, lorazepam, Ativan on the page before. Those are very short-acting agents and can be used to induce sleep. Ambien can also be used to induce sleep. So usually the benzodiazepines and the non-benzodiazepines, the shorter acting, and in the table that I give you, I've got that delineated, are used to induce sleep. The other one would be the melatonin receptor agonist, Rameltion, is also a sleep inducer. The sleep maintenance, so I can't stay asleep or I can't sleep long enough. Those are your long-acting, so your long-acting benzodiazepines. So under that first section, florazepam and temazepam is probably a more intermediate, but they're very long-acting. They've been around forever. They were around when I was in school. Quazepam, very long. It's the longest acting of the benzodiazepines. So it'll keep you asleep for quite a while. Ambien has an extended release product that just releases the drug at intervals throughout the night. So an extended release product could be used. Belsomra is another one to keep you asleep. Trazodone, those tend to do both. They'll help you get to sleep and they'll keep you asleep. Diphenhydramine will do that. Especially if you take it in a liquid form. You'll get to sleep pretty fast and it will keep you asleep. So some of the drugs will do both. Then there's those folks that wake in the middle of the night. The only time I've ever taken these drugs is when I went to China. And at 2 o'clock in the morning, I would wake up because it's 2 o'clock here and could not get back to sleep. So I have used those, and there for the awakening in the middle of the night, we use a dosage form. So the Ambien makes a dissolving tablet or a spray, very quick onset. You go to sleep. I mean, it's just like that. But the caveat is that the manufacturer says you need to have at least 4 more hours that you can sleep without having to get up. Otherwise, the daytime somnolence or sleepiness can cause trouble with your ability to be alert and awake. Okay? So those are the 3 ways we use the drug. We're going to take advantage of their onset and their duration. We're going to take advantage of a dosage form that can deliver the drug quickly for the middle of the night. Okay. Let's see. Under the benzodiazepines, in the middle of page 14, so they reduce the onset of sleep, time to get to sleep, 10 minutes. They prolong sleep time by about an hour. They decrease anxiety if that's what's causing part of the problem, but you've got that impaired memory, anticonvulsant, I don't know why I stuck that in. So the differences we talked about in duration, Trazolam, remember, lorazepam, short-acting. The others are longer-acting agents. Valium is very long-acting, but we don't use it for insomnia. because it is one of those that has lots of active metabolites, accumulates in renal and liver dysfunction, heart and difficulties in the elderly. Long-acting benzodiazepines in the elderly, be careful. A lot of these drugs have active metabolites that are renally eliminated. You've got usually diminished renal function, so they can hang around a long time. Your elderly are going to ask you about drugs to help them sleep because they're not going to sleep as well. Their sleep will diminish over time. They may be used to sleeping 8 hours a day and now they're down to 4 or 5. So one of the things to ask them is, how do you feel when you get up? If you can sleep 5 hours and feel good and get up and do your stuff, then it may be enough. The other thing to ask people about, I don't know if your other lecturer covered it, was do you nap in the middle of the day? If you are napping, then look at their cumulative sleep during the day. If you really want to sleep at night, then don't nap during the day because it will cut into your sleep. I love Sunday afternoon naps, I really do, but I cannot go to sleep Sunday night. So I broke my rule and I took a 2.5-hour nap on Sunday. Well, I couldn't get to sleep until about 2 o'clock in the morning, and I kept waking up, and then I had to be here to go to work. So I won't do that again. But ask your elderly about napping. If they do, then it's okay if they'll nap, but they need to also realize that they probably won't have to sleep that long at night. Common complaint. The non-benzodiazepines are more specific. They don't bring as many side effects with them. So that's good, but they do have some that are a little bit unique to their own. They can decrease sleep latency, meaning how long it takes you to get to sleep, the number of wakings, their sleep duration, sleep quality is pretty good. In terms of, in this class, Sonata, very, very short half-life. So quick onset, get you to sleep fast. It does have the potential for some hangover sleepiness. I'll wait and talk about those as a class. Ambien. So Ambien has 3 different, it has a regular release, it has the disintegrating tablet, it's got the oral spray, it's got an extended release. So they're covering all bases with them. So again, sleep initiation can be used with Ambien, the dissolvable tablet oral spray in the middle of the night, be able to sleep 4 more hours, and then the extended release can be used for both the onset and sleep maintenance. Mental alertness the next day is really a problem with these drugs, and patients need to be warned about them. I'll probably skip, I've got a section on risk and side effects at the end. Yeah, I'll just keep moving through and then I'll touch base with those. Lunesta, the longest half-life. Let's go over the melatonin agonist. I told you about Rosarim. This would be one to use when you need sleep onset and you do not want to use a benzodiazepine or a non-benzodiazepine. So keep it as an alternative. The orexin receptor antagonist, there's only one in this group, and that's the Belsomra. The one thing to note with it is it's a problem when you use it with 3A4 inhibitors. So avoid that because the drug then can hang around a long period of time, and you can get some really bizarre behaviors when that drug stays around for more than it should. So the amiodarone, diltiazem, grapefruit juice, your macrolide, antibiotics, those common ones that we talk about with 3A4 inhibitors, you don't want to use them together. One thing that's down here and also in the side effects section is people who have sleep apnea. They may complain about being tired, not sleeping well, and maybe it isn't diagnosed or hasn't been reported by a spouse. Maybe they sleep by themselves, there's nobody to tell them how they sleep. The use of these agents to help them sleep can worsen or bring more disordered breathing and can lead to more apneic spells. So in people who are, have y'all had apnea yet? Okay. So, screening for apnea, mostly people are gonna have, due to, large girth, not always. Then get those sleep disorders diagnosed before prescribing these long-term, because they can impact their breathing. We talked about, I don't have any other thing to say about the antidepressants. With the diphenhydramine, remember it's on the Beers criteria. It says down here it's not effective in improving insomnia, but everybody knows it helps people get to sleep. But it has a huge hangover effect. So it's really not meant for long-term use. I want to get down to side effects on page 17 and talk about these. Almost all of these agents will cause daytime sedation. So warning people about that is important. Dizziness, lightheadedness, cognitive impairment, so that your mental alertness, your ability to concentrate the next day, make good decisions. Motoring coordination, falls go up with the use of these drugs, so in your elderly, again, can be a real problem. Long-term use can be habit forming. None of these are meant for long-term use. They're all meant for short-term use while you're addressing the problem, but they're not meant as maintenance therapy for the rest of their life. When patients come off those drugs, they will have rebounds insomnia. So working with them to be prepared for that and to address that is important. And to do it at a time where they can deal with it. Let's look at sleep-related behaviors. These are probably the most bizarre. These people have behaviors when they are asleep, but they appear awake that are very abnormal. Let's see if I listed it there. One thing I bolded down there is that 12% of all emergency department visits are for adverse reactions to psychotropic drugs, including these agents, and the majority are in those over the age of 65. So have a healthy respect for these drugs. So the sleep-related are things that people will, you want to advise folks who are decision makers, who are nighttime decision makers. If you have mothers, single mothers that have children, young children that they're responsible for, you want to avoid these drugs. Use other agents if they're having trouble sleeping. Use folks who can work with their social situation to help. People can, there's even it's called sexomia, where people have sex in their sleep. People get up and they do activities in the house without knowing about it. I had a patient who came because she had diabetes, she was having trouble getting pregnant, she had PCOS, her husband came with her, and we were going through the history, and usually I ask people about, especially if they have high blood sugars in the morning, do you get up and eat at night? And she said no. And her husband said, yes, you do. And so then he started to tell me this litany of things that she did. He said she gets up in the middle of the night, she prepares a meal, she cleans up the kitchen, she puts everything away, she may even do a load of laundry, and then she'll go to bed and she won't remember any of it. That's some of this type of behavior. So you have to be careful with, so keep that in mind, and it isn't an uncommon. We had a man who came to the emergency room, and bizarre behavior, didn't know his name, just was not acting right. His family said, we don't know what's wrong with him. They thought he had had a stroke, and what it was a reaction to these a sleep agent. He was on Ambien. So driving, people can drive and be asleep. So sleepwalking, lots of sleep-related behaviors. So keeping those in mind. Let's see, sleep paralysis. The patient can be aware that they are falling asleep, but they cannot move. They will have total inability to coordinate any movement to get up, but they're aware of it the whole time. Let's see. So some of the FDA has come out with these agents in terms of using lower doses, particularly in women. It came out first for women. It said the doses that have been approved are too high and need to be lowered. Same with, they later came out and said the same for men. I asked, last year it came up because there were some women who had pilots for husbands. So I asked Lauren about rules that pilots have to follow, because people have to make nighttime decisions. Like if you're on call, you shouldn't use these products. So I asked her about what the pilots, if there's a rule that they use, because they often are having to adjust to different time zones and resetting their sleep. So what did you find out?
This is from my mother-in-law. So my father-in-law flies, he used to be Air Force pilot, now he flies for American Airlines. But she said, this is with Americans' rules. Yes, he has to be scheduled 10 hours free from duty, so I guess when he stops flying. An opportunity for 8 hours of uninterrupted sleep before any flight duty period, so domestic or international. He also has to certify fit for duty before every flight. If he did not get adequate rest, he must remove himself from a trip. However, there are no special rest requirements for international flights. Then I asked specifically about meds, and she said, melatonin is not banned nor approved by the FAA, but if you take sleeping pills, you have to wait like 72 hours before flying. Then she said, interestingly, Air Force pilots are cleared to use, they call them no-go pills, which is Restoril, and go pills, amphetamines, to help them get over time zone changes and allow them to stay awake during long missions.
Wow. Wow, okay. Restoril is temazepam. It's an intermediate acting benzodiazepine. Okay. So please have a healthy, I guess what I'm trying to get, healthy respect. They have some bizarre effects. You're messing with the brain, and so it will sometimes act out in ways that are can be dangerous to the person and seem odd to the people who are around them. See if there's anything about it. Look on page 19 under potential risk. Pregnancy, time when you don't sleep well. Sometimes it's because you're getting up, going to the bathroom, close to the time you deliver, you usually are not sleeping well. I think pregnancy gets you ready for not sleeping well after you have the kid. But using these agents during pregnancy is contraindicated because of the malformations. You can use Vistaril. You can use a hydroxyzine as a sleep agent though. Alcohol consumption. This is a common problem of overdose, is when patients mix alcohol with one of these agents, particularly the benzodiazepines. So warning patients not to do that. Renal and hepatic disease, keep that in mind, especially with those longer acting benzodiazepines. They rely on the liver to convert them into metabolites, and a lot of times they have active metabolites. That's why they last so long. The pulmonary disease and sleep apnea, so we can worsen that with these agents. Nighttime decision makers, again, clinicians on call, single parents with young kids, people who have these, they work, the swing shift people. They work 3 days of nights and then they're off for 3 days. So they're continually moving back and forth between daytime awakeness and daytime sleep. And then your older adults, so keep those in mind. And these are going to be the folks that come and complain to you about sleep. So having your game plan, how do you evaluate them? How do you help them? Who can you refer them to? Who really needs some kind of agent to help them sleep, and who needs just to make other lifestyle adjustments, or needs to be evaluated for other problems that could be interfering with sleep, like sleep apnea. Questions? Sorry, I kind of went all over the place. The handout's a little bit more organized, and hopefully the table will help some. Questions about the use of these agents? Most important for you is going to be what type of insomnia do they do they treat major side effects? That's all I have. I will see